Hello, everyone, and welcome to our follow-up sessions on case-based learnings focused on the Middle East. Today, we have a wonderful panelists and wonderful presenters. It's my honor and privilege to introduce my co-chairman, Dr. Papalardo. He is the director of Cardiothoracic Intensive Care Unit in Alexandria, Egypt. We have some wonderful cases today. I'm going to get some great insights from interventionalists that really need no introduction. First, I'd like to start off with introducing my colleague, Dr. Mirva Al-Snag. She currently serves as the director of the cath lab at the King Fahd Armed Forces Hospital in Saudi Arabia. She's also actively participates and is on the board of our SCI, which is our National Society, and is on the American College of Cardiology Interventional Leadership Council. So with that, we'll get this started. We're going to try to respect everyone's time. And so, without further ado, Mirvat, welcome, and we're looking forward to your presentation.
Thank you, Amir, for the introduction, and thank you to Abiomed for organizing these webinars. I think it is critical that we share cases and learn from each other, and hopefully improve care that we're delivering to our patients. I guess the theme this time is high-risk patients, or CHIP. Complex high-risk interventions that are obviously indicated. So this is a gentleman who actually was admitted through the emergency room. He's 74 years old, and his atherosclerotic cardiovascular risk factors included diabetes, hypertension, and hyperlipidemia. He had an echocardiogram that showed severe left ventricular systolic function with an ejection fraction of 25%. We, just to look at the timeline, that when we aggressively manage patients by appropriate revascularization and optimize them while they're in hospital, their course is actually very short, which is much appreciated by the patient first and foremost. So the patient on day 1 had his echo and angiography. On day 2, after the multidisciplinary team meeting, we opted to go ahead with high-risk interventions with mechanical circulatory support. And by day 3, he was set to go home. So this is the presenting echocardiogram. As you can see, it's fairly global, with perhaps more pronounced in the anterior segment that you can see on the top of the donut that's right in the middle there. So that was short access. So, you know, there's a lot of data about using lactate in patients who are in cardiogenic shock. The SCI classification has already been released and is actually in the process of being revamped to, you know, change the classification to be more streamlined to what we see in practice. And interestingly, this publication from last year was suggesting that baseline lactate may not be representative or discriminatory as much as that after 8 hours. And you can see here that 8 hours and beyond, you see discrimination between survivors and non-survivors. Nevertheless, and this is based on the IABP Shock 2 trial. Our patient's lactate level was actually less than 1. So we were relatively safe. This is his angiogram. You could see a dominant right coronary artery with atherosclerotic plaques here and there. But what you do see here is a large circumflex coronary artery with a focal disease that includes a obtuse marginal branch, and a proximal lesion in the left anterior descending artery that angiographically we don't appreciate its complexity. We just see, you know, some kind of positive remodeling and haziness in the vessel in both the ariocaudal and iliocranial views that are playing. So as I said, we opted to do a multidisciplinary team meeting. The surgeons, I don't know if you've seen a lot of patients from our part of the world, but a 70-year-old is probably the equivalent of an 80-year-old. They really do have a biological age that's quite advanced, and they're usually very limited and frail. Our surgeons said, you know, although the targets were good, but the quote-unquote, the box was not. And so we opted to treat this patient. Now, I don't have the still or the frame where we were trying to deliver a balloon. I don't think the calcification was appreciable in that segment that I just showed you. So we actually tried to deliver a balloon and it just wouldn't cross. So what we ended up doing is deciding to do an IVUS, and the IVUS wouldn't cross, but what we did see is just before that segment, we saw a napkin ring lesion that clearly needed rotablation. Now, with that kind of an LV, I'm not particularly comfortable doing rotablation, because if they have any kind of no reflow, particularly if these patients already have a little bit of thrombotic, and vulnerable plaque because of the ACS, then they don't tolerate and they really don't have any reserve, and they crump really quickly in spite of having a normal LV EDP, and in spite of having a normal lactate level. The EDP was actually 22 in this patient. So we went ahead and put the Impella circulatory support in, and we actually went ahead with a 7 French XB catheter and started doing rotablator. We actually started with a 1.5 and then a 1.75 burr, which did cross successfully after several runs. And miraculously, the patient tolerated it. Unfortunately, I don't have a screenshot of the hemodynamics, but you could see that the patient tolerated these long runs where we had to go from one burr to the other. Afterwards, you can see a still frame over here on the left-hand side, where you see the balloon is fully inflated, and the lesion did yield. And then here in this angiogram, you can see that we delivered the stent, and we're actually deploying the stent across the diseased segment. And once again, the stent yields very nicely after we did atherectomy in this patient. So we needed 2 stents because proximally the lesion was much bigger. You can see the stent boost over here shows you we're trying to make sure that we don't have a gap between the 2 stents, but you can also appreciate the calcification that's there. We finally deliver the stents, both stents, they're overlapped nicely. Again, you can see it in the middle screen. And then we're doing our optimization and post-dilatation. And this is the final angiogram, where you can see that napkin ring lesion has disappeared. And we did do the IVUS for this patient. This is the final angiogram. You see TIMI3 flow, but you do see that this is a very lazy left ventricle. And at that point, if this patient wasn't doing terribly well and we didn't have Impella circulatory support, I don't think I'd be able to do 2 complex procedures in this particular patient. But we were able to continue because we knew the hemodynamics were well supported, and we went ahead with a complex intervention of the system. So we put 2 wires, one in the circumflex and one in the obtuse marginal branch. As you can see, these images are a little difficult to appreciate the balloons, but I put an arrow there. So we opted to dilate the obtuse marginal branch, which was angulated and difficult to actually cross. And we managed to have the lesion, it did yield. So thankfully, we did the balloon test and it didn't need rotablation either, but that was a concern. So we did something that was a little, out of the box and not conventional, where we chose to, because this was the more straight part of the vessel, was the circumflex continuing on to this very tight obtuse marginal branch that was more difficult to cross. So in those cases, you'd either do a DK crush, which would be multiple steps and would perhaps be too difficult, or the tap into that obtuse marginal branch, and then consider that the main branch, and consider this branch here as the side branch, which was in fact what we did. And here we're putting a long stent in, trying to make sure we have enough for proximal optimization prior to that segment. And so here we're doing proximal optimization. We did recross, but as you can see here, this is definitely pinched and does need to be treated. So it's pinched. You can see where my arrow is. The lesion is pinched, but we do have we recross, obviously, with this segment. We have to recross it, remove the wire that was there, recross it, pre-dilate that segment, do kissing balloon inflations. And when we're ready to deploy a stent, this is again stent boost. It's showing the tap technique. The stent is already deployed in the branch. And you can see a balloon that is there, and we are trying to have minimal protrusion into the other branch when we're deploying the side branch stent. When we're done, we do a kissing inflation and then proximal optimization. I think very critical that when we do something that is not conventional to our cath lab or to us as operators, that we make sure we have accurate reporting for the next time if this patient does come, then they know where the tap was. We tapped into the inferior branch, or we tapped into the obtuse marginal branch. Nevertheless, this was the final result after the bifurcation stenting and the LAD as well. And this patient, again, you see that the LV is still not particularly happy. But I think it's very important at this point to ask whether we should be sending the patient back to the floor with the Impella CP in or out. First and foremost, patient benefit versus risk. Again, having guidance from EDP and the pulmonary artery pressure PAPI. Understanding device management and how it's going to happen on the floor, and then closure and how you want to approach it, whether you're going to close it in the floor or in the unit. I think the patient was doing remarkably well at that point in time, in spite of what the angiogram was suggesting. And, you know, the PAPI, again, this is a very elegant paper published in the European Heart Journal that actually shows that it really correlates very well with stroke volume, and hence very, very predictive of how this patient will be. Closure, again, there are different closures. This is showing, this is a publication by Giuseppe Tarantini. It's a circulation about manta, comparing it to the conventional, in particular, suture-based closure devices. And clearly, suture-based closure devices and mantas fare better than a lot of the others in terms of both major and minor bleeding. This is not the case. There was another patient that we did after that where we tried our first manta and it was proctored, and this is us learning how to do it. And it's just really a matter of really keeping track of how much we, what the measurement was. And it was a very nice dry seal. I think we just took our time in the beginning, but I suspect that once we do these more and more, it'll become another, just a large angioseal where you pay attention to the markers and know how deep you were. So I'm just going to fast forward this a little bit, but this is basically us going through the different maneuvers. I'm sure the operators that are with us today actually know how the manta works. But you know, here we've pulled it, we're just keeping the traction, and I'm not sure, I hope I have at the end when we're done and there's almost no bleeding, and we just observe it. We leave the device down and we just observe what's happening in the groin, and it was a very pleasant surprise that there wasn't much happening in the groin. And so this is a patient that, as I said, came back a month later when we were trying to evaluate him whether he would need a ICD. And he was obviously placed on optimal medical therapy, so he was put on his beta blockers and his ACE inhibitors and sitagliptins and so on. And when he came to us, the ejection fraction, I'm sure you can see here, looks a little better than what it was when he was initially presenting to us. So we continued to treat the patient medically, and he was scheduled for an ICD to be placed at another time. And so I'll stop here, and perhaps the panel can take over with discussion points that we can all benefit from.
Yeah, that was an excellent case, Mervat, and there's a lot that you demonstrated, the utility of mechanical support in a patient with low ejection fraction multivessel disease. You were able to do a lot of revascularization, you use atherectomy, and you were hemodynamically stable. The other thing I think that is critical is your vascular access techniques, which were meticulous, which is really the biggest barrier to utilization of these technologies. So you showed us how you were able to close with the manta. Tremendous case. Dr. Pappalardo, do you have any comments about her case?
Congratulations for the case. It's very interesting. You mentioned the duration of support, which is one of the new issues in the management of these complex cases, because of course, I always call for exploiting the device. So of course, this was an elective case, so the procedure was done, but in cases you have STEMI, despite the revascularization is safely performed in the cath lab, it might be valuable to transfer the patient to the CCU with the pump on board. Can you comment on this, and what is your perspective?
Well, I absolutely agree with you, and I think this is what I was alluding to when I first started my case. I think part of the sharing these cases is, you know, a learning process and trying to improve practices. I think as somebody who's been doing this for 10 years, you know, you weigh risk and benefit. And I don't think our CCU is quite ready to be dealing with routine Impella cases. We're trying to build up that experience. I know there's a huge difference between the experience of our cath lab crew and the CCU crew. So the cath lab, they just know how to whip up the Impella, how to prep it, how to troubleshoot, how to deal with the alarms, and so on. I think the CCU, not so much. And so we've reached a point where we want to make sure they're well aware of how to manage the access if there's a little bit of oozing, how to troubleshoot the alarms, and so on. I would feel a lot more comfortable if I'm able to send these patients to the floor and at least give them the benefit of the device for a little longer to offload them a little bit more. Perhaps I could get away with it with a patient like this where the lactate was reasonable, the EDP was also reasonable, and I wouldn't be able to get away with it in another patient, particularly if a patient who had a complication during the procedure, let's say they did have no reflow. Those are the type of patients that, no, I do want to send him to the floor with some form of mechanical circulatory support. But part of it is building your team. So it isn't enough that me and my cath lab are comfortable with these devices. It's also important that we have a parallel team on the floor ready to manage these patients, because once I'm done with this patient, I have my next patient on the table. So I'm preoccupied.
Yeah, so one comment I like to make regarding keeping the device in, at least in high-risk PCI, if you go back and look at Protect 2, it was low single-digit amount of patients that had to keep the device in. If you look at Protect 3, that series, which was real-world experience, again, it was about 3 to 4%. And now we're doing the randomized controlled trial Protect 4. We anticipate that to be the same. But I think the key factor is one thing that Dr. Mervat mentioned was how the patient did peri-procedural, was the patient devoid of any complications. But I think, in my opinion, the most important thing is the hemodynamic assessment. So in my practice, we do a right heart cath on every one of these patients. And at the end of the procedure, we have baseline, we compare it to the end, and that really guides our decision making. And to be honest with you, if the patient does not need it in based on objective criteria, it's probably safest to have to take the device out rather than transport them and house them in the CCU with the device, because it makes us feel better. So if you think about Protect 4, there's going to be a right heart cath sub-study that is basically going to be mostly be done by the Americans, as the Europeans don't use right heart cath traditionally for high-risk PCI. So this debate has been debated for some time, and the sub-study in Protect 4 is going to answer the question of the utility of the right heart cath. I think it's very important to make that decision at the end of Mervat's case to say, can I take the pump out safely, or do we need to send the patient to the CCU with the pump in?
Amir, just let me do one very last comment. I think that in these elective cases, you might use these cases to train your CCU. Because I think it's strategic to have the CCU ready for your first cardiogenic shock patient.
Right.
And I think that these elective cases can be a great opportunity to train your team. You can transfer the patient. Usually, the patient will not have any alarm or any issue, but you just can use these cases to get the team in the CCU familiar with the device, do some training, so that your first cardiogenic shock patient will have optimal care in the CCU.
That's a great point. Well, that is fantastic. In the interest of time, we're going to continue to our next speaker. Our next speaker is going to be Dr. Pappalardo. He will be talking about, or is it Dr. Clemente? Am I in the wrong order?
Yeah, Amir. So it will be Fabrizio Clementi, the next speaker. He will present two cases. Dr. Clementi is head of cardiology at Sheikh Khalifa Specialty Hospital, UAE. So Fabrizio, please.
Thank you, Federico, for your introduction, and thank you, Dr. Mirbert, for showing us your very interesting case. So I'll go over with mine. Let me share my screen. Okay, I think you can see it now. So I present here one surgical turn down, protected with mechanical circulatory support. So this is 40 years old gentleman with hypertension and uncontrolled type 2 diabetes, which was admitted with an NST elevation MI a few months before. He had already that time a dilated cardiomyopathy, which was ischemic in nature with an ejection fraction around 30%. and a 3-vessel disease with a left main bifurcation. At the time, the decision was for going for bypass surgery, and he received one mammary artery on LAD and 2 venous vein graft, one on the first diagonal and in the right coronary artery. So 4 months later, this patient was out he didn't have any medical insurance. And so he stopped all of his medication, didn't control his diabetes, stopped aspirin and so over and beta blocker. So he developed palpitation, had a syncope, and was admitted again for a suspicious of ventricular tachycardia. At the presentation, he had mild increase of high-sensitive cardiac troponin, ejection fraction dropped to 20%. Now I'd like to show you my screen here with the echo. Echo show clearly a very poor performing left ventricle. We did a new angiography, and you can see here that there is diffuse disease on the circumflex. There is a diffuse disease on LAD with competitive flow, both from the vein graft, which was placed on the first diagonal branch, and there is competitive flow here even on the Lima to LAD or from the native circulation. Another projection, and the RCA is totally occluded. This is the vein graft, which was anastomized on the diagonal branch, and the vein graft going on the RCA, which was still working with a mild disease or maybe intermediate disease on the anastomosis as well. And the Lima, again, here the Lima has some disease in the anastomosis, so this underdeveloped Lima is not very huge vessel. So what to do in this time? So of course, patient will had a fresh surgery with very low ejection fraction, already presentation with the electrical instability, hemodynamically not doing very well, not performing very well. So we decided to go for Impella assisted PCI on the Lima, on the vein graft, and we did even PCI on the circumflex, which was not anastomosed and not bypassed in the surgical. So this is our plan: Lima to LAD PCI, graft to D1, and 6 circumflex marginal native artery treatment. So first of all, of course, look at the groin. Do your injection. You can do ultrasound guided or angio guided. That's your preference. Was a single access on the right femoral groin. You can see here that the Impella introducer. Once Impella is positioned, you can use the same introducer to go for your 6 French, 7 French catheter, whatever you need to do. This is the positioning of the Impella device in the right oblique with the guide. Usually have to be positioned you have to be sure that your device will finish in the apex of the LV in order to have good support. So we proceed with the stenting of the Lima anastomosis, and the stent navigate easily. There was no problem with the treatment of the fresh anastomosis. The stent is well deployed. And then we go over for the treatment of the other anastomosis on the diagonal branch. Even in this case, stent was positioned and the flow was fine. Then again, for the circumflex native artery, revascularization was fine. So at the very end, patient tolerate very well the procedure. He didn't have any hypotension, of course, performing very, very good. So we decided to remove the Impella in the cath lab. We use in this case Tuproglide for closing the groin. We don't have the manta device, so we used Tuproglide technique. Was mild stenosis at the end of the closing. So we give just a small ballooning with improvement of the flow, and after a few days, there was good flow on the right femoral artery, common femoral artery. So patient was doing fine and was discharged a few days later. Then, if you allow me, I want to present another case that we had a few days ago. like 10 days ago. This was a 30 years old gentleman. I know it's strange, but you know, we have a lot of patients who are from South India here, and mostly of them are from Indian or Bangladesh or Pakistani patients. And this guy, they have very severe coronary artery disease when they are very young. So this is a 30 years old gentleman. He has hypercholesterolemia as a known risk factor. He had chest pain since 24 hours. And this is his ACG at presentation. You see here already there is signs of severe involvement of all of the anterior with right ventricular blunt block, already tachycardic. Patient was transferred from another center to our hospital for receiving primary PCI. It was in Kilit 4, already on pressors when he arrived. So RCA was fine, but the left main was totally occluded. So when you have this kind of patient, you know, with 24 hours chest pain, and you find out that he has already left main occlusion, it's critical. You know that you have to act fast. Patient will not tolerate the procedure at all. So there is already a EABP inside. I arrived a little bit later here. I was not in the hospital at that time, so they called me. So I would just perform fast the PCI because I already bought of 2 groin use, one for the EABP, the other one for the catheter, for the guiding catheter. So I just implant my stent very fast, and then patient was already in shock condition, so he need to get over with to step up with the support. EABP was not helpful at all. So we went for we check the groin. You see already the flow is very limited. Groin, the puncture done by the junior interventional cardiology was fine, so I could use that groin to go over with my Impella. So firstly, I positioned my Impella. You see here the Impella tip is not very well deployed, so I recrossed again the aortic valve I removed the device, recrossed the aortic valve, repositioned the device in a good position. And patient, of course, was sent in the CCU with the Impella on. So it was doing quite good for the first 24 hours. Impella was working at P8 with 3.5 liter per minute of flow. Patient was in a acute kidney injury, anuric, so we had to start CRRT. We was on mechanical ventilation, of course. Lactate initially was decreasing down to 5, then start to rise again after 24 hours, up to 12 millimole per liter. Cardiac power have to drop to 0.6. Systemic vascular resistance was in normal range, taken in normal range with norepinephrine. SVO2 was going down to 65%. There was continuous suction alarm by the Impella, so we need to decrease the Impella CP power. There was no response to fluid challenge. ECO was confirmed that the Impella device was in good position, and the wet pressure at that time was around 20. The pulsatility index, the pulmonary artery pulsatility index was dropping down to 0.5 from 1.8. CVP was rising to 25. The TAPSE ECO dropped, so there was clear sign here that there was RV failure, and which, you know, many times when you have severe LV dysfunction, the RV will be involved, even if the RCA is fine. So we don't have Impella RP here in UAE. Hopefully it will arrive shortly. So we went for a VA ECMO, even though the patient didn't need any oxygenator. So we implanted the VA ECMO together with the Impella device. You can see this shot done through a right femoral, a left radial artery. It was very difficult to engage with a small 4 French catheter. There was severe spasm of all the radial and brachial artery. Anyhow, you can see here that device were working together. The aortic valve, you can notice it's not opening at all. So there was no any kind of, you know, power by the LV by itself. And so anyhow, we couldn't save this patient. He expired 5 days later, unfortunately. So that's finished my presentation. Thank you for listening.
Wow. First of all, commend you, Fabrizio, you and your team. That was a very challenging case. That was, you know, the mortality was very high. Just a few comments I would like to make. If that same patient presented our institution One is when on arrival with the balloon pump, we would do the hemodynamic assessment and then escalate. After I saw your left main shot, I guess what I would suggest is if you see a left main like that and you saw the EKG, there was, you could see the RV was involved because the EKG was such a large territory. 40%, what we learned in the cardiogenic shock initiative is that when you have proximal LAD or left main thrombosis, 40 of those patients, percent of those patients had concomitant RV failure because the septals actually provide support to the RV. So I would have put this patient on VA ECMO first and then unloaded with an Impella at first presentation. The second thing is if you look at the interval of escalation of care, when you went from Impella to ECMO at 24 hours, sometimes that's too late. And so we do assessments every, on the cath lab and then every 6 hours. If the lactate in a young patient like this isn't clearing, I guess what I would encourage everyone is to think about escalation very, very early. We learned that from the shock initiative, that the longer that you wait, the less likely you have survival. That being said, even if you would have done all of what I would describe, the patient still had a high risk of dying. So I commend you, Fabrizio, for what you did. It was a very, very hard case. It's very sad because of the age of this particular patient, but I think we're getting better, and in the near future, hopefully we could save these types of patients. Dr. Pappalardo, what's your experience with the case like this? What would you suggest?
I have a couple of comments. First of all, just me comment on the detrimental effects of using a balloon pump, because when you're using a balloon pump, you are delaying approach with a more appropriate mechanical circulatory support. So, and in real life, when the balloon pump is in, the femoral artery has been already used, and you have to exchange the balloon for the Impella CP. So it takes more time and makes the procedure a little bit more complex. The second comment is about timing of mechanical support. As you mentioned, this is the kind of patient I would recommend to put the Impella first and then proceed with the revascularization. This is, I think, nowadays clearly shown by the multiple evidence produced by the DTU trial and the best practices that have been reported in the literature.
Yeah.
The third comment is about the technology. You reported multiple suction alarms. And this is a very important issue because we learned and we know now that suction alarms are one of the tools that the device can provide to the CCU to quickly identify right ventricular failure. And therefore, I think this is very important to inform the community in every group which is managing Impella patients that suction alarms should alert the clinician to look for right ventricular failure and immediately provide escalation. On top of that, that's something that we will discuss later in my presentation. Of course, escalation that does not necessarily mean VA ECMO, because this is typically the case of a right ventricular failure, which is due to left ventricular failure. So you might consider, if the patient is not in profound hemometabolic syndrome, to upgrade just the left-sided pump with a 5.0 or 5.5. Yeah. But I think this is something that we will discuss later in my presentation.
Yeah, I'd like to address a question from the audience. It says, can you explain the rationale of doing the right heart cath in the setting of shock? So here's a patient who comes in shock with a balloon pump, which I agree with Dr. Pappalardo was inadequate support. The right heart cath is key because it will guide your therapy. If you do the right heart cath and you see the patient has a right atrial pressure of 20 and a PAPI of less than 5, then you make the diagnosis at this patient has biventricular failure. In the absence of the right heart cath, you're making the presumption this is left-sided heart failure. And you see what happened to this patient. This patient initially had inadequate left-sided support and had concomitant biventricular failure, and therapy, at least robust therapy, mechanical support, was delayed about 24 hours. And so that's why the right heart cath is extremely critical, because it will guide your therapy and it will guide your response to therapy. So when the Impella was put in, if we do a right heart cath post Impella, you wait 30 minutes or an hour on the table, you can make the assessment if that's adequate support or if there's RV involvement. And that's why in the absence of those hemodynamic assessments, it's very hard to know which device and the timing.
So if I may reply to some of your, your point. So as I said during the presentation, actually it was a junior staff in the cath lab when this patient arrived. So, they didn't know how to, to implant the Impella by themselves. So I arrived after, they already finished with the EABP and, they already have the guiding catheter inside. So at that time I have to decide, okay, I remove the guiding, I go with Impella, or I just, 30 seconds, stent the left main and then go over with Impella. So my decision that time was, okay, I will stent it. I'm here, the wire there. So 30 seconds stenting, then remove the guiding and go back with the Impella. That was the reason why the Impella was not implanted by the beginning. Of course, I know that when patient arrive in shock, usually we go for, more than EABP. EABP, usually we don't use so many anymore, please. But, you cannot always be there. So in those cases, you have to do what you have. So he was not able to implant the Impella by himself. And we did the right cath, you suggested. And I told you, at the beginning, the PAPI was fine, was over 1. So, of course, we could have gone with a VA ECMO that time. We decided for the Impella and patient was doing fine. Of course, as you mentioned before, the CCU have to be very aware, and all the doctors staying in the CCU have to know very well how everything is working on there. So how you have to interpret all these, all these parameters you have. You have the PAPI, you have the cardiac power output, you have the RA pressure, you have the wedge pressure, you have lactate. So are many variables, you have to consider. And as Dr. Mirbat told you before, we are not full of cardiac intensivists. So it is difficult sometimes to follow those patients for several days altogether. So of course, there were signs that this patient had RV failure. We should have implanted the VA ECMO earlier. I'm sure about this. But you learn doing. It's sad to say, but you learn doing. And so you manage and you monitor the PAPI and everything else. Next time, which I'm sure we'll go for much higher support, much more in advance. We don't have the 5.5 liter or the Impella 5. So, what we have to deal with what we have now here. So our armamentarium is Impella CP or VA ECMO. So maybe the choice from the beginning could have been, let's go for VA ECMO, but that moment patient didn't need any oxygenator. We have the right cut saying that RV was doing fine. We know that, most of the RV will go on shock surely a little bit later. So monitor the PAPI or whatever you want to monitor, suction alarm for, to know if the RV is going fine or not. As soon as you have some sign, in my experience, at least when you start to have the first, suction alarm from the Impella, what we do now usually is go with the fluid challenge. If there is no, if you don't solve this, this suction alarm, and I'm sure the PAPI is already going down, and you have to step up immediately. Yes, Mike.
Fabrizio, I actually commend you and your team. I think a year or two ago, no one would have considered escalating this patient. The fact that you did really, I think, is critically important for the audience to understand. So you did the right thing. And if I would tell you this, if you only have Impella and ECMO, that's a very powerful combination. With those tools, you're going to be able to get through most shock patients. My only comment is if you would have went to VA ECMO first, I'd like the audience to understand, this is a huge anterior wall infarct. If you put VA ECMO alone in this patient is probably not going to recover.
Yeah, so, sure.
the key is really venting this ventricle. And that's why what we're going to be seeing in the future is a lot more patients who present with profound shock are going to get Impella, where they're going to give VA ECMO to support the biventricles, and then the Impella is utilized as a vent and also to wean the patient off of VA ECMO. There's a really good paper from Germany, the German experience, showing that using an Impella to vent VA ECMO shock patients had a significant survival benefit. It came at the expense of vascular access, as you would expect, but nevertheless, there was a survival benefit. So VA ECMO alone in this particular case is not appropriate, but with the venting strategy, ideally Impella, you probably give the patient the best chance of survival.
Yeah, I agree with you. I mean, going with VA ECMO for this LV, which was really failing, you know, you'll never get it out. So go directly with the, you know, the Impella. So venting and plus, you know, the support by the ECMO, or, you know, what that was my feeling at that time. LV left main occlusion for more than 24 hours means the LV is done. Correct. So that patient was for transplant. I don't think he could have survived with his own LV.
Thank you for sharing that case. That's a really important case. Thank you so much.
Amir. So there's a question from the audience about combining the balloon pump and Impella. Just let me comment on that, because it's very important that colleagues are informed about the potential risks associated with using the two pumps, because when the balloon pump is inflating, that competes with the flow through the Impella device and provides reduction of velocity in the device. So that turns into a reduced performance, and on top of that, there is a high risk for thrombus formation in the motor. So this is the first reason. The second point is about stability of the device. Of course, you know that the shaft of the Impella device is lying in the descending thoracic aorta, and the counterpulsation and the balloon inflation can promote migration of the device positioning. So currently, I would not recommend to use balloon pump and Impella together.
But indeed, we removed the balloon pump immediately after implanting the Impella. So it was, you know.
Yeah, but there was a question from the floor in the chat. Just to...
Yeah, there's a question in the audience, and I agree exactly with everything that Dr. Pappalardo said, and Mervat actually answered it as well. So we all agree, and for the reasons that were stated by Dr. Pappalardo. Well, in the interest of time, we only have 15 minutes, and we have a really important presentation on escalation and de-escalation strategies. We're going to turn the floor over to Dr. Pappalardo, and again, really like to commend you, Fabrizio, you and your team, for you know, the effort that you did. That was heroic, and sharing that case with us. Thank you so much.
Thank you, everyone.
Okay, so I would like to screen share. Okay. Okay, so good evening, everyone, and thank you for giving me this opportunity to present here about the escalation and escalation strategies with Impella. So we are now moving from the field of protected PCI to the cardiogenic shock patient, and as mentioned before, to the issues that VA ECMO can promote during support for cardiogenic shock. And as already discussed previously, nowadays the Impella or ECMella concept is very popular. We will discuss about that on its physiological basis. But I always like to start from nomenclature, because I think that nomenclature makes the concept nowadays. You know that European countries, and mostly Germany, have started to call this strategy ECMella, whereas in the US it's more popular to use the Impella definition. And I think it's important to share the concept that we currently are using an Impella-based platform, which at a certain point in time might require VA ECMO escalation in order to correct the hemometabolic syndrome or temporary biventricular failure. So I think that the Impella definition is more appropriate nowadays. And that turns also in the new phrasing of using venting, but I would rather use unloading, because unloading is a therapeutic platform which is provided by the Impella device, which goes beyond the concept of surgical venting of the left ventricle. And of course, this is more sound in terms of not only mechanics of the left ventricle, but also to the biology of the myocardium and the chances for myocardial recovery. So nowadays, I think that it's more an upfront Impella therapy, which can eventually require an Impella escalation. And in case you use VA ECMO, there is a huge amount of evidence that VA ECMO alone is not providing the same results as Impella. So we should strongly recommend using an Impella device together with ECMO. And this is important not only in terms of the technique of implantation, but also in the process of care, which I call escalation, de-escalation. But eventually it's the concept of transitioning across devices to have the patient with native heart recovery, or eventually ambulating and waiting for heart transplantation or helvet implantation. And this strategy has also been developed technically, and now we call it the Impella 2.0. So first of all, let me go to the background. I think that VA ECMO alone has no role any longer, because there is a huge amount of data that show that using a left ventricular unloading strategy improves results. And the balloon pump in this meta-analysis has been used in 91% of patients, but yet it has shown better results as compared to VA ECMO alone. On top of that, I want to recall you to the issue of when are you using VA ECMO. With this technology of Impella available in many centers, ECPR, so implantation of ECMO during cardiac arrest, is going to be still the field of application of VA ECMO for the most cases. And these cases are the cases where you have the stone heart not ejecting, not contracting, when you can easily expect the side effects of retrograde flow to the aorta, with LV distension, stasis in the left ventricle, increase in EDP, in wedge pressure, and pulmonary edema. And again, I want to remind you that all strategies that have been developed in order to counteract this side effect of VA ECMO are not as attractive as putting an Impella. And this is very important to remind that not only because Impella provides unloading, but also because Impella is an independent device. So you are using two different pumps to support the patient, and that has a very important role in the perspective of de-escalation and transitioning. The Impella device can be implanted at bedside in patients in cardiogenic shock in the CCU, and that is important in order to optimize the use of resources and avoiding transporting patients on VA ECMO to the cath lab. And it's also, I call it anatomical, which means that by implanting an Impella device, you do not violate key structures in case the patient will eventually need a durable LVAD. So you're not approaching the LV apex surgically, and you're not producing an ASD via left atrial cannula. And of course, the perspective of using an Impella device is very important, as much as we are able to provide the maximal flow, because when you use a PVAD, you produce unloading of the left ventricle, leftwards shift of the PV loop, and you can get complete decoupling or uncoupling between left ventricular and aortic pressures. So how much Impella? I think that the Impella strategy should be exploited at its maximum speed, and we should avoid to use the Impella just to correct the hemodynamics of pulmonary edema, rather to use it at the maximum speed as long as we are able to reduce CVP via draining the right ventricle with the venous cannula of the VA ECMO circuit. Again, there is a consistent body of evidence. We have retrospectively showed that in a preliminary study from 2 centers, one in Italy and one in Germany. And these results showed that in these very sick patients with cardiogenic shock and a high rate of patients who had received CPR, we were able to show that the hospital mortality is significantly lower in patients who have Impella as compared to ECMO alone. And more important, left ventricular ejection fraction at weaning showed a trend towards a more significant native heart recovery as compared to VA ECMO alone, despite we had a small number of patients in our study population. And these results were simultaneously replicated by a US group, which showed that Impella patients have improved survival similarly with the same figures. And their study, in my perspective, was very interesting because they were also able to show that with this strategy, you can quickly wean the patient from inotropes, which are one of the toxic therapies that we still provide to this patient population. At the end, our multi-center study was published in Circulation with more than 500 patients. And again, the results were replicated. So VA ECMO patients plus Impella. So Impella patients had improved survival as compared to VA ECMO alone in the overall population and in the propensity match population. In all groups of patients of risk profile, presentation of cardiogenic shock, and severity of shock as assessed by lactates level and by scores which can predict survival rate in ECMO according to previous evidence. Of course, you have two important vascular access, and that has to pay the price in terms of increased risk of vascular access complications, both bleeding and ischemia. But in these regards, improvements are being put in the field, and there is more and more experience in using the CP device with a percutaneous approach on the axillary artery with excellent results. And similarly, we can exploit the axillary artery to implant simultaneously the Impella approach, the prosthesis, which is connected to the axillary artery, and in which you can implant separately the arterial return cannula of the ECMO and the Impella device. But what makes the difference on top of using an unloading strategy with Impella is timing. So we have to be very, very timely and very, very cautious in monitoring the patient and identifying the strategy in less than 2 hours in order to change the story of these patients. And I do like this concept, not only in this regard of survival rates, raw numbers, but also in the granular description of what is the patient's course after you have an Impella strategy. Because Impella can provide you a platform to quickly wean your patient from the toxic facts of ECMO. So inotropes, mechanical ventilation, ECMO itself. You can ambulate the patient, so you can wean the patient from the hospital bed, and you can safely bridge the patient to an helvet or heart transplantation. This is more and more important as you can use the axillary artery for ambulation, And you can use the axillary artery to escalate the patient to a more powerful pump, such as the surgical 5.0 or 5.5. And again, this is the concept that I recommend in evaluating escalation. So if you have a patient who is on a 2.5 or CP device and you're still administering inotropes and your inotropic score is more than 20, or you have signs of metabolic decompensation or end organ damage, you have to consider MCS escalation. And this MCS escalation can be univentricular. So if you have just LV dysfunction, and you can electively upgrade the system to an axillary approach with the 5.5 or 5.0 in order to have prolonged recovery. You can optimize and treat complications, and you can also thoroughly evaluate the patient for neurology. If you have biventricular dysfunction, so the patient is suffering from left and right ventricular dysfunction, this is something that is very urgently required to be treated. And you can have, again, in this case, secondary RV failure, as the previous case was described, in which you have high CVP, but the wedge pressure is very high and PAP is very low. So you can consider escalating just the left-sided pump, or you can have a primary right ventricular failure in which the left-sided pump is working fine, but the CVP is high. And so you have to consider right ventricular support, either with a bipella strategy or an ECMO on top of Impella. I think it's very important to consider that you can have also some mechanical troubles on the lungs and some technical issues on the device to be ruled out before you proceed to this escalation. But then you can also have the need to de-escalate the patient and to consider weaning. So when you have resuscitated a patient with Impella on top of ECMO or ECMO alone, and within 48 hours of evaluation, you have myocardial recovery, you can wean from ECMO safely. But if you don't have signs of myocardial recovery and the patient is still on hemometabolic syndrome, so inotropes still with lactates, still not passing urine, you have to continue support with 2 pumps. But if you have the patient who has recovered from the cardiogenic shock syndrome, but has no recovery of the left ventricle, you can provide de-escalation with implantation of a 5.0 device in the axillary artery. And once the 5.0 device is implanted, you can remove the ECMO if the right ventricle is fine, or if the right ventricle is still failing, you can keep the patient on extended support with ECMO until the strategy is defined for the long-term support. So again, the patient is on the escalation. So you have signs of normalization of lactates, you have no inotropes, you have everything fine with end organ function. You can consider the escalation and weaning from Impella CP or 5.0 or 5.5. If you have no recovery, so the left ventricle is still failing, and you have to provide the patient access to durable devices or heart transplantation. But when you have native heart recovery without any sign of valvular dysfunction, complete revascularization, no inotropes, regression of end organ damage, you have started to give also some medications for heart failure, and the Impella pump speed is reduced to a low level, you can consider Impella remover. I want to remind you that this process is not easy if the patient is on a 5.0 or 5.5, because the amount of flow which is provided on a P3 speed is significant. So you have still a very important hemodynamic support. This is also very important in the perspective of implanting a durable helvet. This is the largest series ever published on transitioning from temporary to durable circulatory support in Europe, more than 500 patients. And we have shown that if you are implanting an helvet on a patient on ECMO, the results are going to be very dismal, with more than 50% of hospital mortality and more than 50% of patients requiring an HRVAD for right ventricular failure. So I think that the new perspective in this regard is bridging these intermax patients from VA ECMO to LVAD via the escalation to Impella 5.0 in the axillary artery, which will provide the patient the opportunity to full recover, ambulate, and electively be implanted with a durable LVAD. This preliminary series that we published has shown that very sick patients with ECPR and very profound cardiogenic shock were able to be bridged to a successful durable LVAD via axillary implantation of the Impella 5.0 with excellent results and 100% survival rate after LVAD implantation. Thanks for your attention.
Dr. Federico, that was an excellent presentation, very comprehensive, and actually that's one of the best, most contemporary presentations I've heard on the treatment of particularly escalation, and everything you've said is really is true. So thank you so very much. I presume there's got to be a lot of questions. That was a lot of information in his presentation and a lot of data. If we have any questions or Mervat and Fabrizio, do you guys have any comments on escalation? I thought that was a very, very compelling presentation.
It was very, very thorough, and thank you for doing that. I think there's somewhere in there where we have to factor in futility as well. So, as we're determining where the patient, which direction the patient is heading, I think it is critical that the care team has a conversation with the family and sets expectations very early on. And the other thing is what can be very frustrating for those of us who have treated these patients is it's not very linear. So some patients can start to improve and then they can bounce right back down again, and you need to re-escalate therapy and then they improve. And so anything can set them off if they bleed a little bit or if they have a superadded infection and what have you. So that can shake things around, and the team has to be prepared for that. So the escalation and de-escalation is just not one course. It can go up and down, and you need to be ready for it and have multiple conversations with the family.
Dr. Pappalardo, I have a question for you, Dr. Pappalardo. In your presentation, that is true here in the U.S. centers, particularly in Michigan, when we're considering patients on VA ECMO to go to durable VAD. The outcomes have been not very good and now becoming prohibitive. You mentioned that a better strategy would go from VA ECMO to a surgical Impella 5.0 or 5.5. My question to you is, what about the right ventricle in those patients? Because we know that usually what we have is unrecognized RV failure in those patients, and that seems to be one of the reasons they do so poorly when they get a durable VAD. So in your practice or your recommendation, do you just want is it univentricular support off of VA ECMO, or is it biventricular support? Or do you have an experience or any comments on that?
So that's a very important question, because I think that for sure the key factor which is driving mortality when you are transitioning from VA ECMO to durable LVAD is the right ventricle. Okay. And we all know that the right ventricle cannot be thoroughly evaluated when you are on VA ECMO support. Okay. So I think this is very important because if you put an LVAD such as an Impella 5.0, you are doing an LVAD test. So indeed, you are testing the right ventricle, and eventually you might avoid a futile durable LVAD implantation. So this has a double perspective, is improving the patient and optimizing the patient in the perspective of an helvet implantation, but on the other side is also allowing clinicians to thoroughly evaluate the right ventricle and eventually avoiding a futile helvet implantation. So I think this is very, very innovative, and I think this is a real game changer in the field of patients management for durable support.
Yeah, just one comment to the audience regarding the right ventricle. We do not have, at least in the US, and I'm not aware of Europe, of an approved durable right ventricular solution. And so that is a big problem, an unmet need in this space, is having a durable right-sided implantable device. And so as Dr. Favillaro mentioned in his presentation, that's one of the biggest limitations. And we're seeing the same problem here in the US.
Yeah. About futility, because Mirvat mentioned futility. I think futility is, again, is of course one of the most relevant steps in patient's management. But I would like to stay away from futility in the very first days of support. So at the very beginning, we have learned that the patients can recover if you have adequate circulatory support. Of course, that takes time. So we cannot expect that a patient who has been in profound cardiogenic shock for 48 hours can immediately recover his kidney function or his neurological status. So it takes time, and we have to be cautious, of course, with relatives, but also we cannot discuss about futility too early. The other?
Sorry, there is one group, Dr. Pappalardo, where I'm personally convinced that there is futility that we should talk about early. And I could tell you in our experience here, not only in Michigan, but in the initiative, is an octogenarians who present in shock, who use mechanical support for device in these patients. You know, our survival rates are very, very poor in the United States. I think I agree with you when you talk about holding off on making a decision for futility, like in Fabrizio's case, the man is 30 years old. But as we start to see older patients, if we were very aggressive in treating them, at least in the 80-year-old and above population, it's been very poor. We've actually changed our institutional threshold, and at 75 and above 75, we're very, very hesitant to implement a mechanical support for above 75 in profound shock, because we have had bad outcomes, to be very honest with you.
Yeah, that's an excellent comment. Of course, in Europe as well, we do not implant a patient who's older than 75 unless there is a very good reference status previously, and we are confident that we can make it just with an Impella, but we would never implant a VA ECMO in a patient who's older than 75. Okay. But if you have a STEMI in a 78-old patient, and you have the access to go safely with an Impella, we would use an Impella.
May I ask you a question, which is, related to cardiogenic shock with in a very special setting? So if you have a patient presenting with left ventricular septum rupture, so VSD, after a STEMI, which is your preferred treatment or choice for mechanical circulatory support in this case?
I'll give you my experience. We had a series of 5, and the problem with that is right now there's no particularly if the VSD is very big, there's not a percutaneous solution. Okay, so you can't really put a closure device there. The second problem is that you need, when the surgeon wants to repair this, the tissue is too friable and frail. So the surgeon will always tell you, I need time. And so what I've done in our practice is we would put these patients on biventricular support with Impella. We have a series of 5, and we would try to let the patient live as long as possible. Usually the surgeon wanted 2 to 3 weeks, sometimes longer. And I have to be very honest with you, in the 5 cases, and even some of them were young, with that particular strategy, all of our patients died. So I could, I don't know the right answer for this. I know there's been people who've reported putting these patients on VA ECMO with an Impella as a bridge to surgery. But in my experience of 5 cases in the last 2 years, we've never had a survivor. So I don't know about Merva and Dr. Pappalardo, if you guys have, what's your experience at your centers?
So I would comment on this, first of all, by stating that, of course, this is a very challenging disease, and that very much depends on the timing and the opportunities that you can offer the patient. So if the patient is not suitable for a percutaneous treatment and therefore requires at least 2 weeks to wait for surgical treatment, I think that VA ECMO is futile, because you can't keep a patient alive on VA ECMO for 2 weeks with a VSD and then undergo surgery. That will fail for sure. So I have experience with the left-sided Impellas, and that has improved our results. But of course, we have to remind that that very much depends on the size of the VSD and the hemodynamic impairment. So of course, the cases that we were able to treat with an Impella CP, of course, had a slightly lower hemodynamic impairment as compared to those who required VA ECMO.
Because we have 2 cases of young patient as usual, large VSD couldn't be closed with percutaneous treatment. So there was an option, how can we let them survive for these 2 weeks the surgeon needs before we can go through the treatment. And we went for Impella CP with similar to Hamir. We didn't have any good result at the very end. So in 2 years we did 2 of those cases, but nothing. So I didn't know if maybe VA ECMO plus Impella would change something or not. So that was my question. I think it's limited for every center. There's not so many VSD around. That's
There's a proposed strategy of LAVA, which I don't know if Dr. Pappalardo, you guys are doing at your center, but we take a cannula and basically put the cannula across the intraatrial septum. We simultaneously unload both the RV and the LV. And this has been proposed, and there's been maybe a couple cases, I think, down at Emory where they've showed some success in getting these patients, keep them alive till surgery. The problem with just having an Impella CP at your institution, Fabrizio, is in people who have very large VSDs, eventually your RV is going to fail, and it's going to be a major problem. And so unless you could provide a safe, durable biventricular support until surgery, I really don't know of any really good solution. I agree with Dr. Pappalardo on this one.
I think with these patients, it's really the 2-week wait is a selection bias. Those that are very sick are going to drop off the wagon sooner, and the ones that are more likely to perhaps survive or have a better chance of survival are the ones that are going to be alive for the surgery at 2 weeks. And so the options are limited, perhaps tandem heart and what have you. I know we deviated to shock on complications of MI. My case was not really that. It was a high-risk intervention. So I think just for the purpose of the audience, Amir, I'll ask you, how do you decide that which cases? I mean, I'm sure you don't do all your rote ablations or all your bifurcation PCIs with mechanical support. So how do you choose which patients require it and which you can get away without it?
Yeah, that's a great question. And I don't think the answer is as very simple as an algorithm as you see at a lot of the meetings. It's multifactorial. It's really, the comorbid conditions of the patient, the severity of the LV dysfunction, the amount of revascularization you intend to do, how much a global ischemia do you have. So if I'm operating on a bifurcation left main that's calcified in an 80-year-old patient who has an EF of 20, and they have a big normal right coronary artery, I would use mechanical support in that patient. If I was doing the same case on a patient who has a shaft or an osteo left main, I probably would not use mechanical support. The EF alone is really not a good marker for you to decide what to use Impella or MCS. The classic example I give is the patients who have normal ejection fractions, bifurcation left main, and a totally occluded right coronary artery. I don't care if the EF is 65 or the EF is 15, that patient's going to have hemodynamic instability, particularly if you're properly doing the case, using advanced imaging techniques, doing DK crush, doing a kissing balloon at the end and so forth. So to answer your question, Mervat, it's a combination of the comorbid condition, the revascularization strategy, and the ejection fraction all together will help you decide if the patient needs EF. One alone or in isolation is not going to be really enough for you to make that decision. So
yeah, I agree with you. It's in our institution actually. Yeah, ejection fraction is one player. I'm not saying it's not one player, but of course, when you go on left main and restart occlusion of RCA, it's it's another point, especially if you will go for two stent technique on the left main, and so I think it's multifactorial. So there is no and then that the case that you are using it, they will not actually have any benefit maybe, but then when you're not using it and you will have a crash, and then it's too late to do anything. No, you will not be in time to implant the Impella and hope to have a good result. No?
Yeah.
So may I ask you, Mirvat, I think it's very important that we discuss the concept of surgical turn down, because I think it's important that the surgeons are informed about protected PCI. So the question is, are they just rejecting the patient because they think it's at too high risk, or they are making a wise decision and because they know that there will be the chance to perform a safe revascularization with the Impella device? So what is the current status in your country?
So I'm glad you said that. I think it is important to have a conversation and understanding with your surgeons and to have a heart team decision that at the end serves the patient really. So it's not just about high risk. Unfortunately, diabetes, for example, is very prevalent in our part of the world. So if they're not diabetic, they have impaired glucose tolerance. A lot of these patients have diffuse disease that's really, renders the vessels poor targets for bypass. That is one of the most important reasons that patients are turned down. There's just diffuse disease and no place to plug in the graft. Another one is, as I mentioned in my presentation, our patients are not as active. Once they hit above 65, you will see that they have an extremely sedentary lifestyle. And many of them are very frail, even though they're obese, by the way. So they can be obese. It's not about being thin or obese or overweight. So they may be overweight, but they're actually limited mobility, require a lot of assistance, and so on. So I think there's a global look at things. So one is to look at the targets, if they're suitable or not. One is to look at the patient themselves and how they will recover. Another is to look at the other things such as diabetes that is extremely poorly controlled, and they're concerned about healing and mediastinitis and so on in the recovery period afterwards. So there's a lot that's actually factored in. On the other hand, they may be more inclined to do a case that has concomitant valve disease that requires valve surgery and so on. So I think the conversation has to happen with the surgeons first and then with the patient and their family.
So guys, go ahead. I think my only comments is that we're getting close. I think we're over time. If anybody's willing to stay, then, and the faculty is, I'm okay with staying a few more minutes. I just would like to really compliment, our presenters. They're really just tremendous cases. And interestingly, I like to also compliment Dr. Federico. I get to do this a lot all over the world and work with colleagues, but it's rare that we work with non-interventional cardiologists who do this all the time, that actually have the depth of knowledge. And I think that adds a tremendous dimension to your institution. And I think Mervat was right. We don't all have the luxury of having a person like you in our institution, which I think really increases the quality of care and the survival for, I think, the highest and the most sick, high acuity patients that we take care of. So Dr. Papalardo, we encourage you to train other people and send them to our institutions so that we could have this type of support. But I learned a lot, and I would like to actually invite you, it's on more panels at least, and share your experience with our American colleagues, because it's actually an unmet need, like Mervat mentioned, per region. It's also an unmet need in our country here. We don't have dedicated people in the ICU. It's usually myself and my partner, Dr. Schreiber, who take care of all these patients. And it's very labor intensive, very hard to do procedures and care for them in the ICU. So your patients and your institution is lucky to have you. Thank you for sharing your knowledge.
Thank you, Amir. It has been my pleasure to be here on board with this faculty for this webinar. And I have also to admit that it's my pleasure to get this recognition, because I always recommend that education should be devoted also to CCU and to this new professional profile of cardiac intensive care, which is something that it's definitely necessary, because as you mentioned, these patients are so complex, can get any kind of complications, and so you need a dedicated team to look after these patients who has you know, the basics and the concepts for getting the patient out for native heart recovery with you know, excellent results. Yes. Nevertheless, I have also to admit that the colleagues in the Middle East are doing a great job, and they are gaining more and more experience. Definitely, I would be happy to support for doing more cases and more education in the field of intensive care.
Yeah, when we started this series with Mervat, we wanted to really focus on high-risk PCI patients. And I think, you know, a credit to our colleagues in the Middle East, it seems like the learning curve and trajectory has been as excelled, and it's excellent. You heard the conversation today really get into very complex cardiogenic shock and complications of MI and the utilization of these devices to support that. So I'd like to continue this series, and we could talk offline, maybe Mervat and our Fabrizio and Dr. Pappalardo to see if we could continue to focus maybe on a session just on shock, because I learned a lot in this particular session, and I hope our audience did.
Thank you.
Sure.
So I think the session is coming to an end. I have had the opportunity to share excellent cases from Middle East and with a very expert panel. And I hope that we will have the opportunity to deliver this therapy and these opportunities to all patients around the world. Thank you very much for joining us tonight. And greetings from Italy, not Egypt, Amir.
Okay. Did I say Egypt?
Yeah.
Egypt.
Sorry about that. Probably the Middle East theme got to me.
Yeah.
You guys
Bye-bye.
have a wonderful weekend. God bless you.
Thank you.
Assalamu alaikum.